Pleasure this morning to welcome all of you and to welcome Nikki Mason to give the invited seminar for the Cancer Center. And I've got some notes here so that I don't get it wrong. But one of the things that Nikki told me I wasn't allowed to say this, but I'm going to anyway. Before she went to vet school, she actually served in Her Royal Majesty's Secret Service. And she gave up the license to kill to become a veterinarian, but she still drives a cute little convertible. And there's a danger to society in Philadelphia. So when you guys see the little red convertible, if you're in Philadelphia, just get out of the way. I think she's still I think she's still packing, by the way. So, but anyway, after her life as a secret agent, Nikki went and completed her veterinary degree from the University of London in 1992. And then she became an adopted child of the University of Pennsylvania, where she completed her residency in internal medicine and her PhD in immunology, working in Carl June's group. And after postdoc experience at Penn, she joined the faculty at the vet school, where she's now associate professor of medicine and is really doing some exciting work in cancer clinical trials and in immunology. So today she will talk about her clinical experience using a genetically modified Listeria to break tolerance to tumor antigens in osteosarcoma in dogs. And she will tell us about 2 clinical trials using this approach. Is firstly the same thing as Bigley? Just checking. First in the setting of minimal residual disease, and then in combination with radiation to stop tumor progression in dogs with metastatic disease. So please join me in welcoming Nikki.
Thank you, Jaime. I'm not sure Bigley is a word. Is Bigley a word? I don't think it's a word. So thank you very much for the invitation to speak here today. And as Jaime says, I want to just present some of the work that we've been doing using a genetically modified Listeria to try to prevent metastatic osteosarcoma. So I'm going to present that first and then talk a little bit more about some of the early work we're doing with combination radiation and immunotherapy in osteosarcoma. So I think it's worth starting with the problem. Pediatric osteosarcoma is a highly aggressive mesenchymal bone tumor. It occurs in around about 800 people or so a year in the United States. Most of these are children. It tends to occur very classically, I think I have a pointer here, but it tends to occur classically in bones of the appendicular skeleton, arising in the metaphysis of the bone, as you can see here. And this is a very classic radiograph that we'll see. As you can see, there's areas of lysis there. There's some early proliferative changes. This is a knee of a 7-year-old boy. The pain that he was experiencing was non-responsive to non-steroidal anti-inflammatories, so he had radiographs taken. These are certainly concerning for osteosarcoma. He had an MRI, which you can see next to that, and you can sort of see the extent of this tumor present here on MRI. A biopsy will confirm, thank you so much, a biopsy will confirm the, will confirm the diagnosis of osteosarcoma, where we see large malignant osteoblasts. This is osteoblastic osteosarcoma in this tumor osteoid, this eosinophilic osteoid. And the classic treatment for this in children is neoadjuvant therapy with MAPs, that's methotrexate, adriamycin, and platinum compounds, and then that's followed by limb salvage or limb-sparing surgery in most cases. And in fact, that's what this particular individual had. Here are his radiographs after MAP, and you can see some progression of the tumor. Here's the actual surgical specimen. Here's obviously the tumor. And then he had reconstructive surgery, a cortical allograft, which unfortunately went on to fail, and he ended up with a prosthesis. And he had about 90% necrosis in his tumor, which is actually a good prognostic factor, suggesting that he was going to go on and do well. Unfortunately, however, that didn't happen, and he went on, like 30% of these children, to develop metastatic disease. Had 3 subsequent thoracotomies to cut out the metastatic lesions, which is standard of care in children with metastatic osteosarcoma. He went on to ifosfamide, and then he had several clinical trials, but unfortunately died when he was 11 from metastatic osteosarcoma. So there is no effective treatment for metastatic osteosarcoma in children, number one, and there's also no really good way to predict which patients are going to go on and develop metastatic disease and which ones are not. And you can see that 70% of these children actually go on and do very well. So 30% of them, unfortunately, will develop metastatic disease and die. As you know, because you're big players in the comparative oncology world, dogs also develop osteosarcoma, but they do so at a much higher incidence. So we see around about 10,000, probably more than that, cases of osteosarcoma in dogs a year. And this tends to occur in middle to older age animals, so a bit different from the human situation, and in large and giant breed dogs. But we do see a lot of similarities. So we see the lesions developing mostly in appendicular skeletal bones, again arising from the metathesis. We see lysis, we see proliferation.
But they're not seeing that today, Brett.
Fracture.
That's just every other time they said it to me.
Again, our histopathology looks really similar. Again, malignant osteoblasts in this eosinophilic osteoid.
Like, can we
and our
see the
treatment
people
of choice is
could we
upfront amputation.
see their camera or something?
Here, and on occasion limb salvage experiences.
The way they were judging if we could see it was whether we were looking at the
contrast
screen.
to humans, however, the majority of our patients will go on to develop metastatic disease, from which they will die, usually within about 8 years. So median survival time 10 to 14 months, and that sort of. Have a model here where we can actually start to look at ways in which we can prevent metastatic disease, because in our canine population with the current standard of care, that is inevitable. And this is just work I put in here by Melissa Paoloni and Chan Kana, just to emphasize the fact that canine and pediatric osteosarcoma are really very similar. So gene expression profiling, I think the dogs are in red and the children are in blue. You can't see a difference between gene expression profiling between canine and pediatric osteosarcoma. And we see very similar genetic abnormalities, mutations in P53 and P10 and retinoblastoma, dependence on the mTOR pathway in dogs, just as we see in children. So we think that really what we need to do here is concentrate on preventing metastatic disease. And to be fair, it's not as if people haven't been trying. So this is a rather sort of disappointing summary of 20 plus years of work where people have been trying to prevent metastatic disease in dogs. And you can see combinations of amputation and carboplatin or cisplatin, carboplatin and adriamycin, some additional bisphosphonates being added in, David Vale with gemcitabine, and then Cheryl London at the bottom right here using metronomic chemotherapy and tyrosine kinase inhibitors to try to prevent metastatic disease. But across the board, I think you can see that we have failed to budge median survival time using a multitude of approaches. And this has been the case over the last 20, 30 years. And yet the field now recognise that we need to focus on prevention of metastatic disease, not treatment of it. So we certainly need to pay a lot more attention to that. But we do know, when we think about the historical views of this, that osteosarcoma is an immune-responsive tumour. We know this from the work of Bill Coley back in the late 1800s, using Coley's toxins, basically Serratia and Streptococcus all mushed up and injected into these people to try to stimulate immune responses and providing some improvement in survival. Obviously, these weren't controlled clinical trials, but certainly anecdotally, some of these patients going on to do much better than expected. And rather interestingly, we have a similar sort of corollary from work that has been reported by Duncan Lascelles and others as well, that demonstrate that canine patients that actually have limb-sparing surgery that becomes infected with bacteria, and that's quite a high percentage of these, about 68% of them become infected. Those dogs go on to do much better. They develop metastatic disease, in this particular paper, around about 22 months median survival time, compared to 11 months if you don't develop a bacterial infection. So this tells us that there's something about bacterial infection, there's something about perhaps immune stimulation, non-specific in this instance, that could actually provide some sort of survival benefit and prevent metastatic disease in this very aggressive tumour. And you can see then in the last sort of 50 years or so, people have actually been trying to utilise ways to stimulate the immune system to generate immune responses against these metastatic cells and eliminate them with varying degrees of success. and certainly up front using more general immune stimulants like BCG or these muramyl tripeptides, which seem to produce some sort of survival advantage in dogs and actually went on to be approved in Europe for the treatment of non-metastatic osteosarcoma in children. IL-2 being used, inhaled, Shankana's work, some adoptive T-cell therapies, Salmonella to deliver IL-2, some cell-based vaccines, Jaime's work with Fas ligand gene therapy, inducing inflammation in these tumours, and then later on, now some of the work that I'm going to show you with Listeria. So people have recognised for a while osteo is immune responsive, and we have to find a way now of generating ideally specific immune responses against the micrometastases to try and prevent these patients, human and dog, from dying. So what makes a tumour immunogenic? And I think that there's a flurry of papers that came out in sort of 2013 that started to explain this. And it really depends upon their mutational load. So if you have a lot of genetic mutations, a lot of somatic mutations, and that's seen here on the y-axis, and then on the x-axis here are all the different tumour types that they looked at in humans, and this is a Nature paper from 2013, you can see that these vary in the number of somatic mutations. The prevalence of somatic mutations differs between tumours. If you look at the right side of this curve here, you have diseases, you have tumours such as melanoma, non-small cell lung cancer, transitional cell carcinoma. These are classically immune responsive tumours. And they're immune responsive, we believe, because they have a very high mutational load. And that sort of is generally predictive of the neoepitope burden that they're going to have. So the immune system will see these cancers and see these proteins as being foreign. So it's easier, of course, to break tolerance. There's no tolerance to these foreign proteins. And it's easier then for immune therapy to go after them and get rid of them, compared to the immunologically cold tumours on the left-hand side that do not contain very mutations. They can be chromosomal translocations, but they don't have too many mutations. And these tend to be non-responsive to immunotherapies. And in fact, recent work out by the Children's Oncology Group has sort of put osteosarcoma about in the middle here with 1.2, on average, 1.2 non-synonymous somatic mutations per megabase. So these are basically mutations that are going to be expressed and therefore, we think, recognized by the immune system. So that puts osteo, it's not on this because obviously it's not that common a cancer, in the middle here. And so the suggestion is that the immune system could see these altered proteins and actually play an important role in eliminating them. So could we actually look at a way then of stimulating immunological response against a target that perhaps is shared? Because one of the things about these neoepitopes is there's not been shown to be any specific mutation that occurs. We see a lot of mutations in P53, but they're all different amongst individuals. So unless you're going to target that with a neoepitope vaccine that is personalized for each individual, you have to look for a target that perhaps is expressed by all these tumors, or many of them. And the target that we were interested in looking at is HER2/neu. So as you know, an epidermal growth factor, a receptor that has been shown to be expressed in 40 to 60% of pediatric osteosarcomas, and also in around about 40% at least from the work out of Colorado State of canine osteosarcomas. And we also see HER2 being expressed in about 60% plus of metastatic lesions in people, and we also find similar figures there from our own unpublished work in metastatic osteosarcoma in dogs. What's particularly interesting about HER2/neu is that there's now supporting evidence to suggest that it is expressed in tumor-initiating cells. And they see that with breast cancer, that tends to be HER2 positive in the tumor-initiating cells, and in pediatric osteosarcoma as well. And this seems to be, in some cases, independent of the HER2 status of the primary tumor. So you could have a HER2 negative breast carcinoma that actually has HER2 positive tumor-initiating cells. And again, when we think about trying to prevent metastatic disease, you could argue that the HER2 status of the primary tumor, particularly in osteosarcoma, is irrelevant because that tumor has now gone, it's on the pathology slab, and now you're going after the micrometastases. So this is an interesting sort of suggestion and some supporting evidence that needs to be beefed up a little bit. But we do know that tumours that do express HER2 tend to be aggressive, they tend to metastasize early, and so in certain situations we think that this is a very important target. unlike HER2 expression in breast, we don't tend to see gene amplification with HER2 in osteosarcoma. And what's rather interesting about it as well is we tend to find it in a cytoplasmic situation. We tend not to find it on the membrane, where classically you will see it in carcinomas. This is a transitional cell carcinoma from a dog here, and you can see very clear membranous staining. That is not the case in osteosarcoma of either pediatric or canine osteosarcoma. We see it in the cytoplasm. And in fact, when Children's Oncology Group looked at trastuzumab, a monoclonal antibody that targets HER2/neu, they found no improvement in children with this antibody therapy. And it's very possible that it's because the HER2 target is not on the surface of these cells. So whilst it is not a target for monoclonal antibody therapy, it will potentially be a target for T-cell therapies. And I think that that's something that we have to bear in mind, and that's what we're going after. And this is just a Western blot here confirming in a number of dogs that we see different amounts of HER2 being expressed in these tumours. So how are we going to drive a potent immune response against HER2 to try to prevent metastatic disease? And this is where we turn to Listeria monocytogenes. So people have used bacteria, as you saw Salmonella there, and other bacteria to try to combat cancers. So why are we picking up Listeria? Well, Listeria has a very interesting biology, and we can actually utilize that to trigger both innate and adaptive immune responses against antigens of interest. So as its name suggests, monocytogenes, this is a bacteria that likes to go to mononuclear cells, which happen to be, of course, antigen-presenting cells. And when that Listeria is taken up into the antigen-presenting cell, it gets engulfed in a phagosome, as you would imagine. And then the lysosome comes and fuses with that phagosome. And as the pH starts to drop in that compartment, that induces the Listeria to produce a protein called Listeria lysine O. And that is a pore-forming protein. And it basically will punch holes in the phagolysosome, and it will enable Listeria to escape from the phagolysosome into the cytosol. And obviously the Listeria lysine O will come with it. So now what we have is we have Listeria lysine O, and we have the Listeria itself in the cytoplasmic portion of the cell. And this means it is now subject to a manipulation and processing through the MHC class I pathway. And so we have a mechanism here by which we can genetically modify our Listeria and send it into antigen-presenting cells, and that will then be processed and presented on the surface of the cell, both in the context of MHC class I and MHC class II. So we should be able to induce very strong T-cell responses, both CD4 and CD8 T-cell responses against antigens of interest. LLO is a very interesting molecule. It basically has pathogen-associated molecular patterns, so it is a very potent inducer of innate immunity, cytokines, IL-6, IL-12, and it also has this interesting, although poorly understood, property of affecting regulatory T cells and myeloid-derived suppressor cells within the tumor microenvironment, not only reducing their numbers, but reducing their ability to produce IL-10, for example, and arginase 1. So we look upon this as a sort of an immunotherapy rather than just a vaccine to stimulate T-cell responses. There is a component of addressing the microenvironment as well. It's also a bacteria that's very easy to manipulate, so we can change it, we can attenuate it, and we can fuse tumor-associated antigens onto a truncated Listeria lysine O molecule, and therefore use that to take that antigen of interest into the cytosol of the cell. So how do we attenuate this organism? Well, the one that we're using in clinical trials currently is what we call a DAL-DAT, delta-acta deletion mutant. And basically what it is it basically doesn't have ACT-A, and that is a gene that's involved in polymerization of actin and allows Listeria, once it's in the cytosol, to get onto an actin skeleton, polymerize it, and move to a different cell type. So it doesn't have, oh dear, we don't really need that, do we? Oh dear, 50% discount. Maybe I should do that. So it doesn't have ACT-A, so it can't actually move around the cell, and it doesn't have DAL and DAT genes, which basically are genes that are going to make D-alanine synthase. So without this, it can't make a cell wall. So it's a very feeble bacteria. But into that, we can transfect this plasmid, and this is the plasmid that we're actually going to be using. You can see a truncated LLO here, and then you can see extracellular domains of a human HER2 and an intracellular domain there, and that's the fusion protein. And that plasmid is maintained within the Listeria by this sort of auxotrophic complementation here of the DAL gene. So obviously only those bacteria that contain that plasmid will survive. So there's no antibiotic resistance here, and that's of course very important when we think about trying to get this through the FDA. You don't want to be putting antibiotic resistant bacteria out into the environment. So this is how we deliver this antigenic payload through this plasmid, and this just shows you here, I mean, it's all going wrong now, isn't it? This just shows you here the identity of the extracellular 1, 2, and intracellular domains between human and canine HER2. So very high sequence identity that you see there. Oh dear. Okay, so I just want to take a couple of slides to show you some of the mouse data that's come mostly out of Yvonne Patterson's lab, and she is basically the microbiologist that has really developed this strategy. And some of these early experiments just basically demonstrate that you can use this approach to eliminate established tumors. So you can see here in the first experiment, mice are taken, they're given subcutaneous injections of a mammary carcinoma line that expresses rat HER2/neu. The mice are then vaccinated with various constructs that don't have this chimeric molecule, but instead have the extracellular 1 domain or 2 domain or 3 domain of HER2/neu. And you can see here with these mice, they have palpable tumors. They're then vaccinated with these various constructs. And you can see that those directed against the extracellular domains will actually control the tumor and in some cases eliminate the tumor, as compared to a PBS control, and importantly, as compared to another Listeria vaccine that is containing an irrelevant antigen, which is actually the HPV16E7 oncogene. And this is important because what it tells us is that this effect is more than just a Coley's toxin effect. You have to have this directed against an antigen to have the anti-tumor effect. You can't just put Listeria in and watch the tumor go away. So it is antigen dependent. And we see a similar sort of thing with the intracellular domains of HER2 as well. So that's important. We also can demonstrate in this experiment here, taking mice, these don't have a tumor burden, they are vaccinated, the splenocytes are harvested, and then they're just looked at in a classic cytotoxicity assay, where you can see you developing cytotoxic CD8 positive T cell responses against tumor targets that are expressing HER2/neu. And what you can actually see here is this is the product that we're taking into the dogs, the Advaxis 31164. This is again Listeria that has that chimeric human HER2/neu protein that basically contains the immunodominant epitopes of HER2. Then we have one here that just is the intracellular domain, and again you can see the Listeria only control does not stimulate any immunological responses against HER2/neu. Also, and this touches on this concept that these Listeria vaccines tend to have an effect on regulatory T cells. You can see in this experiment, the approach is again to provide the mouse with a subcutaneous HER2-expressing tumor, vaccinate them, and then take the tumors that are remaining and evaluate them for regulatory T cells. And what's interesting here is you can see these are the untreated mice, where you can see the regulatory T cells present here. And with the Listeria control, as well as that targeting HER2, we see a reduction in regulatory T cells. So you don't need antigen targeting or antigen-specific targeting for the effects on the tumor microenvironment, but you do need antigen-specific targeting to see the actual tumors disappear. So that's an important point. And finally, we can look at this model here, which is really trying to address this concept of epitope spreading. So obviously when we target a particular antigen with any targeting approach, we will perhaps drive immunological pressure to develop mutations or escape variants. And the thing about Listeria is it can actually induce epitope spreading. So the model here is taking the mouse, giving them a HER2-positive tumor, vaccinating them, and this time the vaccine that's being used is a vaccine against VEGF receptor 2. So it's Listeria that contains the mouse FLK, which is essentially the homologue to VEGF receptor 2. And what you can actually see here in this particular graph is that that can actually control these tumors when you go against the extracellular 1 or intracellular 1 domain of VEGF receptor 2. But what's important is then when you take the splenocytes of these mice and ask them, do they have immunological responses against HER2/neu? The answer is yes. So you can actually develop immunological responses against HER2, although you've gone in with a vaccine that is targeting VEGF receptor 2. So the concept is that you're probably generating immunological responses, damage, inflammation, and you're starting to drive that cancer immunity cycle of release of antigens that then are going to be processed and presented on the surface of dendritic cells to stimulate HER2-specific responses. So there's suggestion here that we can get epitope spreading. And then finally, we can look at this experiment, which addresses this concept of can you prevent metastatic disease? So mice that are vaccinated up front with a HER2-targeted Listeria and then injected with HER2-expressing breast cancer cells. And you can see with a control Listeria, you do not get control of this metastatic disease, but with the HER2-targeting Listeria, you can see that you get good control. So again, emphasizing the fact that this isn't just a Coley's toxins effect. You need to have antigenic targeting here to be effective at eliminating the metastatic disease. So could we take this now into a clinical trial and ask the question, could we prevent metastatic disease, not in a mouse model, but actually in dogs that we know are going to go on and develop tumors, metastatic tumors? So we designed this study to basically take patients that were coming in through the veterinary clinic, diagnose them with osteosarcoma. They would undergo standard of care amputation and then 4 doses of carboplatin chemotherapy. 3 weeks after that last carboplatin, we would screen these dogs and make sure that they didn't have any metastatic disease. So this is important. We are selecting a population that don't have metastatic disease at this time point, so we could ask the question, can we prevent metastatic disease when our immunotherapy is given in the context of minimal residual disease? We then gave 3 vaccinations. This is live attenuated Listeria, HER2 targeted, given systemically. It's given intravenously, and it's given 3 times 3 weeks apart. We then staged the dogs 3 weeks later and look at them every 2 months. And then we actually went on and added booster vaccines every 4 to 6 months. That was an add-on at the end. So our primary outcome was safety. Is it safe to inject dogs with live Listeria? And this was a 3+3 dose escalation. And to look at the maximum tolerated dose of this HER2 targeting Listeria. And then the secondary outcomes, looking to see if we could generate immunological responses, look at disease-free survival and overall survival. So these patients had to have evidence of HER2 in their tumor. At least 10% of their osteoblast had to be HER2 positive, and no other systemic disease, and importantly, no cardiac issues, because HER2 is expressed in the heart, and we know that there can be synergy between HER2 targeting therapies and adriamycin, which is why we didn't use adriamycin up here. So there is a concern when we're looking at HER2-targeted therapies of potential cardiotoxicity. So they were all screened by echo and EKG and cardiac troponin to make sure they didn't have cardiac issues. So these are the groups. It's probably a little bit too small to see, but we had 3 dose groups across the board generally, apart from one Cavalier King Charles down here, which is a bit of an outlier. We have large to giant breed dogs, variety of tumor locations. Proximal humerus tends to actually be a poor prognostic factor in our dogs, most of them osteoblastic. The grades here graded by a clinical anatomic pathologist, and then the HER2 score, which was basically based, a combination score on intensity of staining and distribution of staining. And then we had dogs having 2 times 10 to the 8 colony forming units through to 3 times 10 to the 9 colony forming units. What happens when you give live Listeria intravenously? The dogs develop a fever. I think you can see that here after about 4 hours. We're seeing around about a 1.5 to 2 degree increase in body temperature that is transient and comes down at the end of the day. We didn't see any particularly statistically significant difference between dose groups in terms of fever, and we didn't see any evidence of dose-limiting toxicity with respect to hypotension, which has been reported in humans receiving a similar Listeria platform targeting E6. So what about the adverse events? So we've talked a little bit about the pyrexia that you can see in these dogs, which again is transient. We also saw some transient nausea and vomiting at the time that temperature is high. It's pretty much like clockwork in that 2-hour period. Temperature rises and the dogs feel nauseous. In terms of arrhythmias, we saw a couple of dogs developing some VPCs that seemed to be self-limiting. We did have one dog develop an accelerated supraventricular rhythm that was non-responsive to treatment. The dog was asymptomatic and actually went home, and a week later his heart rhythm and rate was normal. We saw some thrombocytopenias, which we thought is associated with an acute inflammatory response, and we saw some transient increases in some of these transaminases, which makes sense because Listeria is in fact hepatotropic, and so in the mouse models we do see some inflammation in the liver. But what about survival data? What happens to these dogs? And so this is put up here. Now, just to orientate you, this is a control group, and this was a historical control group. And these are dogs that have HER2-positive tumors. They've been amputated, they've had carboplatin, and they were shown to be free of metastatic disease at the time they would have received the Listeria vaccine. And that is one of the reasons why you can see that the median survival time of our historical control group is a little bit longer than what we classically see, because we've selected a population that don't have metastatic disease. But I think you can see with the vaccinated group, we were starting to see a separation of these curves, and what we sort of talk about raising the tail, which I think is always amusing when you're talking to veterinarians because they think about it in a different way. But this curve is, you can see the tail is raising here, and we're starting to get a plateau out here. And these time points really are quite long. So we're looking at 4.5 years now for some of these patients without evidence of metastatic disease. And you can see our median survival time, 956 days, with a 2-year survival of 67%. And based on this data, this product hopefully will move forward for a conditional license for veterinary usage in 2017. It's also moved into a phase 1b clinical trial in HER2-positive pathologies in adults, and has orphan drug approval and a fast-track status for pediatric osteosarcoma, which obviously we're very happy about. But the question then is what's doing this, and is there any evidence that this is immune and what's happening? So we actually looked at blood parameters 24 hours after these patients received their vaccine. And what we found, certainly statistically significant though, in the higher dose groups, was increases in white blood cell counts in 24 hours, increases in neutrophils, and a decrease in platelets at 24 hours. When we actually looked at that across the board in terms of the different dose groups, we didn't really see a very clear difference between the doses. So in other words, whatever dose you get, there's no sort of big difference in the increase in white blood cells or neutrophils that you see. But what was quite interesting, even though this is a small group of dogs, 18 dogs in total, what was quite interesting is that if we divided those dogs up into those dogs that lived for more than 18 months and those dogs that died before 18 months, you could start to see differences in their white blood cell count. So potentially if you see an increase, a large increase in white blood cell count, this tended to suggest that that patient was going to go on and do well. So a suggestion that the early inflammatory response is in some way indicating how these patients might in fact respond and how well they might do. But do we see evidence of T-cell responses against HER2/neu? So this is a sort of a terrible slide, really. But what it's doing is it's trying to indicate to you the immune responses that we see. So these are HER2-specific interferon gamma ELISpot responses. And so the dogs in their different treatment groups are down the Y here. And then you can see the time points across the top, the baseline, and so forth. And really what we're looking at here, we looked at EC1, EC2, and IC1 responses. And I'm just showing you IC1 here, 98% homology between the human and the canine. And you can see that in the majority of dogs, all of them except one, who actually turned out to have a nephroblastoma, and that's what he died of, have no evidence of immunological responses at baseline to HER2. You wouldn't expect to, right? You should be tolerant to it. But as you go through the vaccine course, you can see at 3 weeks after the last vaccine, we start to see some individuals developing quite strong immunological responses against HER2. But what was equally interesting, perhaps more interesting, is when you go out further to 2 months after the last vaccine, 4 months after the last vaccine, now you start to see more dogs generating immunological responses, whereas they didn't sort of so much up front. And so one of our thoughts there is perhaps that we're being primed to see HER2, but we don't pick up these responses early on. But then as tumour starts to come back, and as you start to see more target, you start to see expansion. It's a hypothesis. You start to see expansion of HER2-specific T cells. And in fact, when you look at the clinical course of disease, this sort of 2 and 4 months shown here is about 8 to 10 months after these dogs are initially diagnosed, which of course is the time that we classically see them developing metastatic disease. And to support this hypothesis, you can see I've put in grey bars here when the patients actually relapsed, when we found metastatic disease. And you can see that some of these patients develop very strong responses when they actually have tumour burden there. So clearly not effective enough to prevent metastatic disease, but we do tend to see those responses amplifying when we actually see clinical disease. So the thought process may be that we see this amplification in some dogs when there is subclinical disease coming back, and that in some cases is able to control or possibly eliminate. And then you can see the overall survival times here of some of these dogs that have developed early immune responses going out 4 years plus. It seems that you have to be primed with this approach to develop these responses, because if you just take a control group of dogs that arrive and have metastatic disease and we look at HER2 responses, they really don't tend to have immunological responses. So you need something more than just having metastatic disease to generate these HER2-specific immune responses. So we definitely can break tolerance to HER2/neu in these dogs. Whether this is relevant in the control of osteosarcoma, we don't know. We know that antigen-specific targeting is important to have clinical responses in the mice models, and it's more of a Coley's toxins. It's more than just Coley's toxins. But the jury is still out as to whether this is truly a HER2 effect. We did treat a few dogs, 5 dogs, with pre-existing pulmonary metastatic disease. And what's interesting here when you just look at these 5 is that their HER2 scores, excuse me, in general, tended to be quite high. And these are the individuals that obviously developed metastatic disease during carboplatin chemotherapy. So they were coming to us and we treated them on a compassionate care basis. The first 3 dogs just got 1 vaccine before their disease advanced and they were euthanized. So we don't feel that we gave them a great shot. But what was interesting is we were able to learn a couple of things from this one dog who came to us with a small lesion in the cranial lung lobe here. We took her, we vaccinated her with the standard course, and you can see we watched over the period of time this lesion get larger and larger and larger in her chest. I was trying to make the case that this could be a big immune response around the tumour, but nobody really was buying it. I wasn't buying it either, really. So what we actually did is, what was interesting is despite that, and despite such early relapse, this dog actually, the rest of the chest was still clear of metastatic disease. So we teamed up with one of our surgeons, Jeff Runge, who was looking at using indocyanine green to recognize tumours and presence of tumours in the lungs. And he gave us a good deal on his surgical approach. So we dosed her up with indocyanine green and we took her to surgery. And this was done in a minimally invasive way. And you can see the nodule here that correlates with the radiograph glowing nicely under near-infrared light. But what was interesting is in other normal parts of the lung, we also saw a signal suggesting that there was inflammation there or tumour there. And despite the fact that we hadn't seen it on radiographs and we hadn't seen it on CT, this was a suggestion that there was clearly tumour there. So part of this was taken out with this nodule, and we were able to look at it by histopathology. And you can see this is the lung nodule here. There's a lot of necrosis and hemorrhage. There's sort of like what appears to be some sort of capsule here. And when we actually looked at that by IHC, you can see all these CD3 positive T cells lining up around the outside of this metastatic lesion. And when we actually looked at the area that was showing up under near infrared, we saw areas of inflammation that were basically CD3 positive T cells. And when we actually stained those up with vimentin, we were able to identify individual cells with mitotic figures that were surrounded by T cells. Now, we don't have a confirmation that these are tumor cells, that our T cells are eliminating them, but I think that this is the first hint that perhaps this is one of the ways in which we are preventing these dogs from developing metastatic disease. We have T cell responses that can eliminate micrometastatic disease, a hypothesis that we need to obviously move forward to support. And so the question then is, if we have this sort of, if this occurs in a number of dogs and we can call these T cells into the tumor, how do we make them effective? Why are they not effective? Well, certainly capsules, high intratumoral pressure, all the things we usually talk about. Immune checkpoints could be problematic, and of course the immune milieu that's present. And so I think that we are very interested, of course, in moving forward and thinking a little bit more about combining this approach with an anti-PD-1 that might enable these cells to actually function more. And then we might be looking at combination therapies to treat metastatic osteosarcoma, both in dogs and in people. So mechanism of action, we think we're inducing HER2-specific CD8 positive and CD4 positive T cells. They are capable of eliminating micrometastatic disease in the lungs. We believe that there certainly is a role of the innate immune system to play, perhaps producing IL-12. We know that to be the case, and then we know work from Jeannie Kleineman has demonstrated that can cause increase in FAS expression on metastatic cells, and then as they pass through a FAS ligand-rich environment like the lungs, they can be eliminated. And there are also, of course, other components at play as well, but this is our starting hypothesis here. I want to change gears in the last just 10 minutes just to talk a little bit about some of the early work that we're doing with combination radiation and vaccination. Radiation is not a common method or modality of treatment for children with osteosarcoma, but we do use it a lot in veterinary medicine, particularly for patients where owners choose not to amputate the dog's legs. These dogs are usually very large, and we use palliative radiation. We know that radiation can synergize with immunotherapy through some of the mechanisms that are reported here. So radiation causes immunogenic cell death, exposure of calreticulin, upregulation of MHC class 1. It can bring in dendritic cells. It can increase FAS expression on tumors. There's a number of ways in which radiation can make tumors more immunogenic, can release these tumor antigens, which can then be presented. And this is responsible really for the abscopal effect, where we can direct radiation at a primary tumor and see elimination of metastatic tumors in certain patients. So if we combine our Listeria therapy with radiation therapy, could we in fact see a response in the primary tumor as well as prevention of metastatic disease? And this is just work demonstrating, this is actually with a prostate PSA-targeted Listeria in mouse models, demonstrating synergistic effects between radiation and the Listeria approach. So the mice being given a PSA expressing tumor subcutaneously, then receiving one dose of Listeria, then hypofractionated radiation, 10-gray radiation, and then following up with 2 additional doses of Listeria, and showing that there's a synergistic effect, which is this black line here, between the radiation and the vaccination alone. And this basically indicates tetramer staining, showing that if you combine radiation with vaccination, you can induce a larger number of tumor-specific, PSA-specific CD8 positive T cells. So we designed a clinical trial for people who had decided they did not wish to amputate the dog's legs. The dogs would have a biopsy to confirm osteosarcoma. We took all comers, regardless of their HER2 status, because we felt that people wouldn't subject their dogs to a biopsy which has a risk of pathologic fracture if they couldn't get onto the trial. So that's going to be a retrospective analysis. These dogs had to be free again of metastatic disease in the chest, so we could give them a good chance to get these doses on board. We gave them 2 doses of radiation therapy, 8 gray, on 2 consecutive days. And then we just followed them up with vaccines every 3 weeks. At this time point here, 70 days is the median duration of pain relief with just radiation alone, and 133 days is the median survival time with radiation therapy alone. So we thought that if we got them through to 8 vaccines, then we would be doing okay, and then the idea was to boost them every 2 months. And I was saying last night that my supportive colleagues at Penn termed this the Hail Mary study, because this is a very aggressive tumour, and the chances, I think, of this working were thought to be fairly low. Excuse me. We recruited 15 dogs to this study, very classic large breed dogs, a number of proximal humerus, obviously lesions in there, osteoblastic. We still have the pathologists helping us with grading and HER2 expression here. But you can start to see that a number of these dogs were actually able to get their full cohort of 8 vaccines and actually went on to get additional vaccines. And some of these dogs with survival times around about 800, 600, 800, 700 days. So some of these dogs are going out 2.5 years without amputation and without development of metastatic disease. This is very, very unusual in veterinary medicine. Again, these dogs develop fever 4 hours post-administration, but we don't see that fever changing with the ongoing vaccine. So the adverse effects that they develop at the first vaccine is exactly the same as the adverse effects at the 2nd and 3rd and 8th vaccine. No changes in cardiac issues and no major changes in liver values over 8 treatments. So this was particularly interesting. I'll just show some radiographs from a couple of these patients. So this is one of our dogs here with a proximal humerus lesion, biopsied, clear osteosarcoma, that received her 8 vaccines, and you can see she did, I thought, quite well. She came back in June, and she was doing quite well. She had a low-grade lameness. Her tumour did look as though it had increased. There's clear soft tissue swelling here, and we sort of thought this was probably progression. She came back again in November, and you can see that the tumour seems to have stopped radiographically. Looks exactly the same as it did, perhaps a little bit smaller than in June. And the same thing in January, and then a year later, so now we're out 2 years, we can start to see very clear progression of the tumour. No evidence of metastatic disease in this dog's chest, and she actually survived another 7 months and was euthanized due to lameness of unknown cause in another limb. So we don't actually quite know. But when you actually see this dog, I think it's worth just showing some pictures.
Good girl.
Oh, you don't need to hear me.
Good girl.
Maybe you do. Okay, so here she is laying on the left forelimb, and here she is now a year and a half later. This is without pain medications. I think it is quite dramatic. Not the only one. Here's a distal femur. You see the same situation. Very little progression. No clinical progression, no radiographic progression, until perhaps the later stages here we're starting to see some proliferation and starting to see some degree of progression. Again, no evidence of metastatic disease, and this dog is currently out 2.5 years, again with no pain meds. Here he is, left distal femur lameness associated with his osteosarcoma. These are dogs that are symptomatic when they come to see us. And here he is then 2 years later, just with 2 doses of radiation and immunotherapy. So we've also had dogs where their tumours, as you can see here, distal tibia, treated with the 2 doses of radiation and immunotherapy, almost seem to be healing. You can see a sort of some additional bone being formed here. And this dog was doing remarkably well until he started to run on a treadmill for some reason, not clear why that happened. And his tumour started to progress about a year or so later. He then, because he was doing well, the owners opted to amputate him. He was amputated, his chest was clear of metastatic disease. He underwent standard 4 doses of carboplatin, and we saw him very recently doing very well. And again, no evidence of disease in his chest. So I think what this starts to speak to is perhaps we should be considering a combination of radiation and immunotherapy, perhaps as neoadjuvant therapy, to induce immunological responses that can start to get going and prepare and eliminate micrometastases before these patients undergo amputation and then potentially chemotherapy. So I think we perhaps need to start thinking a little differently about how we treat osteosarcoma in these dogs. And then we have, again, some evidence of odd effects on metastatic lesions. So this is a dog here at his 8th vaccine that he has evidence of tumor. And as you can see, as he goes through his 2-month checkups and vaccinations, this tumor seems to come and go. And it reminds us a little bit of this histopathology that we saw from that original dog, that perhaps we are looking at some sort of inflammatory response coming and going here. And so this dog actually did very well for 18 months and then had primary tumor progression and was euthanized. So we didn't really shift the time to progression or the median survival time to any great extent here. But what we did do, again, is we see this sort of lifting of the tail of this curve with some of these dogs going on and doing very well following this sort of treatment. And a number of them actually going on and having amputation when their legs actually progressed, which is something that the owners had decided initially against because the dogs were doing well. And only 5 of these dogs developing metastatic disease, several of them when they were out 700 or 800 days. Does this work on metastatic osteosarcoma? I guess we'll find out. This is a dog that came to us in May or June of 2012 and actually underwent the first study. I like this video because it's sort of the Baywatch video, you know. And she now, after 4.5 years, has developed what appears to be metastatic osteo. And so she was switched onto this trial. And here she is just a few weeks ago. So this is in her left forelimb. And she seems to be still using that pretty well. Again, still no evidence of metastatic disease after 4.5+ years. So we'll see how she gets on. So we have a subset of dogs here that seem to be responders. How do we predict those that will respond and those that do not respond? That's obviously an important question. We are interested now in moving on with these dogs. We still have a lot of work to do, looking at tumor-specific factors. Are the tumors different between these dogs that respond and don't respond? Is their mutational load different? Is the tumor microenvironment different? What about checkpoint expression? And there's a whole other concept that Listeria could actually infect these tumor cells and be present there. And we have to look at that too in some of these patients. And obviously we're also interested in looking at the immune-specific factors that are present. So I think, when we sort of step back, our Listeria acts on a number of places in this very important cancer immunity cycle. Radiation may be playing an important role in releasing tumor antigens, supplying the immune system with tumor antigens. And then our LLO therapy acting to stimulate innate responses, to activate dendritic cells, to pick up these tumors, then specific targeting of HER2 and epitope spreading that will allow a broader immune response, and then perhaps some influence or effect from the mouse models, haven't shown this yet in the dogs, that there could be effect of these Listeria on the tumor microenvironment itself. So I think certainly some interesting clinical impressions here. Still a lot more work to try and recognize exactly what's happening, but promising approach. And so I'd just like to thank all the people in my lab who have worked hard on this and some of the other things I'll talk about tomorrow. Obviously the radiation cardiology surgical team, the pathologists, the Perlman School of Medicine, Yvonne, who's a microbiologist, and it's really her work that is shown here. Advaxis, who have supported these studies, funding sources here as well, and obviously the oncologists that refer to us. And with that, I'd be happy to try and answer any questions.
So we have time for a few questions. Aaron, here.
I'm curious whether this is going to be a difficult question because immunology is kind of weak, but if you look at naive dogs and naive humans, as in those who have not received any sort of HER2 activating antigen, do they differ in their rates of initial response to HER2/neu?
Yeah, so we've not looked at that. Classically, you would not expect these patients to have immunological responses against HER2/neu. So they should be tolerant to it, to a normal HER2/neu that's not mutated. And we don't have any evidence to suggest that this HER2/neu is abnormal. We don't see mutations. We haven't looked in these dogs, but HER2 mutations are not something that is reported in osteosarcoma. So we don't expect to see mutations in HER2. And we don't expect to see these patients having pre-existing HER2 responses. Right, so that is true. That is true, I did. That patient actually was an interesting one. It had nephroblastoma. And we haven't screened to see if that is actually overexpressing HER2/neu. It might be, and we have to look at that. So maybe that is in some way stimulating an immune response against HER2. But the majority of dogs do not have evidence of immunological responses against HER2, even if they are presenting with metastatic disease. Again, we saw one of those dogs with evidence of HER2 immune responses. So the majority of them don't have that, but we can break tolerance to it using this approach. So I have not seen any work that looks at pre-existing HER2 responses in children with osteosarcoma. The work that's been done there has been with trastuzumab, looking to see if you can target HER2 on the surface of the cells. And generally speaking, we don't see it on the surface. Now, that having been said, people are now looking at CAR T-cell therapy using single chains and have shown that on certain osteosarcoma cell lines, you can see HER2 on the surface, and you can see it by flow cytometry, suggesting that it could actually be there, but perhaps our IHC techniques are not sensitive enough to see it on the surface. But it could still potentially be a target for something like CAR therapy.
So in many of your protocols, you're using this Listeria over and over and over again.
Yes.
And one of the things you might predict is that you generate an antibody response to this that might clear it rapidly upon subsequent infections. And so I'm wondering, does it happen? Because you might expect that then to limit or possibly even eliminate the adjuvant effect. And a related question is, do you actually know if those subsequent infections actually do any good?
Yeah, so those are great questions. So yes, I think it is highly likely that we generate immunological responses against Listeria, and that's on our list of things to do, so we can go back and look at PBMCs. Generally speaking, Listeria does not promote a very strong antibody response because it's all intracellular. So it finds this way of moving from cell to cell. This one doesn't, of course, it's a deletion. So generally we don't find humoral immune responses against Listeria. But yes, absolutely, repeat injections of this, I would think that we're going to develop T-cell immunity against Listeria. I think that's a given. Does that negate its effect? I don't think we know that yet. I think that there are certainly schools of thought coming out of Albert Einstein that Listeria's, one of the key effects of Listeria, which I didn't touch on at all, is the fact that it can actually infect the tumor cells themselves. And that actually makes those tumor cells a target for Listeria-mediated immunity. So it's actually more of a Listeria infecting the tumors rather than this or in addition to antigen-specific stimulation, if that makes sense. Is it required to keep going? We don't know. My thought process would be yes. I think, giving these dogs with these aggressive tumors 3 doses of vaccine and letting them go, my guess is that that's not going to be sufficient, and these patients need to be kept being reminded of the antigenic stimulus, and something is controlling these tumors for at least 2 months, right, in between each of these booster vaccines. So we've got our immune analysis to do to see if our HER2-specific responses are maintained. You saw in that initial interferon gamma ELE spot that in many of those dogs, they're not maintained. They seem to disappear, and yet the dogs stay clear of metastatic disease. So does that mean we're just looking at the wrong thing? and something else is controlling them? Or does it mean that the immune response up front is capable of eliminating the tumor, and so your antigenic stimulus goes away? And I think these are all questions that we need to try and answer. We don't know.
Thank you so much for the great talk. I just have a quick question about, you said that you didn't stratify the dogs in the last trial on HER2 expression. I'm just very curious to see if you've just quickly looked at whether the ones that responded really well are actually perhaps HER2 overexpressors, or
yeah. So we sort of
preliminary.
We have sort of looked at some of them. We haven't looked at all of them, and the honest answer is it's all across the board. So when you look at HER2 expression in osteosarcoma, and you sort of got a feeling of that from one of the first slides, it's really patchy. So some of the cells will express HER2, others cells around those will not express HER2. It's not very clean at all. From our preliminary evaluation, no, there doesn't seem to be any evidence that those that are strong expressors do better. Also, sort of a follow-on from that question is when we've looked at the metastatic lesions that develop in these dogs in that first trial, they are also HER2 positive. So it's not as if we are growing out HER2 negative clones. We see HER2. We haven't sequenced it, so we don't know if we haven't done that depth of immunological analysis. But the metastatic lesions, many of them are HER2 positive when they develop.
Thank you. So I'm wondering, in follow-up to the question regarding the potential for neutralizing antibodies, what was the rationale behind choosing intravenous administration as opposed to like transdermal that we're fairly familiar with for other immunologic therapies, or potentially intratumoral?
Yeah, so good question. The thought about giving it systemically is that that's the best way we're going to have to stimulate immune responses. If we've thought about giving it into the tumor, and the concern there is it's a live bacteria, so if we just deposit it in the tumor, there'll be a potential for abscesses formation. And so we chose not to go that route, although people have thought about it. And then similar sort of thing with giving it under the skin. The concern is if it's all going to sit there, it could just start to multiply. And this has a very, very rapid replication time. And I'm always a little bit concerned about that going out into private practice, because you make this drug up and you get busy and you go and take a phone call, and in your bag, your Listeria is going to be replicating. So it's actually a dose that could continue to increase unless you put it in immediately. So there's going to be some steep learning curves there. But so that's the real sort of reason, that depositing it in certain situations and without it going into intravenously, there's a potential for abscessation.
So other than radiation, have you, or would it make sense to use some other approaches to stimulate the immune response, cytokines, or even the checkpoint blockade drugs?
I think the checkpoint blockade would be, the inhibitors would be really exciting to use, particularly in sort of the metastatic settings and the primary settings as well. I think we're just sort of looking at the tip of the iceberg here, how to use this immunotherapy and many other immunotherapies in combination, because that's going to be the answer, I think. It's not just going to be a single thing. The concept of radiation, of course, is that we'd sort of supply the body with all these tumors so we get a polyclonal response rather than just targeting HER2 new. Chemotherapy may well do the same sort of thing too. So I think we really don't know how best to use this yet. But I sort of like the idea, and I know sort of Jaime's embracing this as well, of treating these patients prior to amputation. Because we always talk about using immunotherapy in the setting of minimal residual disease, because that's when it's going to work. So we've got no tumor microenvironment, blah, blah, blah. But of course, that's when we don't really have any tumor antigen either. And so, we have to think carefully, I think, about how the best way is to use these types of therapy, what window of opportunity we have before the patients will deteriorate or metastasize. And there's a lot more work to be done.
So I'm going to have one more question, but before Antonella asks her question, I do want to put in a plug for Nikki will be speaking at the vet school tomorrow at 3 o'clock. She'll be talking about some of the exciting work she's doing on CAR T cells for lymphoma. So we welcome all of you. It's in the Animal Science Vet Med building in St. Paul campus, room 125 at 3 o'clock. So hope to see many of you there. And we'll have one more question because we've gone way over time. It's great to see so many people engaged. So, and I know our Nikki's next meeting is not for another 10 or 15 minutes, so she probably can take a couple of questions personally. Antonella?
Thank you for the great presentation. I really enjoyed it. I was wondering if you can just explain the rationale for how you chose the timing between the booster vaccinations in your first trial with the chemotherapy versus the second one with the radiation therapy. And I personally think it's really fascinating that we're starting to change a little bit the perspective of radiation therapy, which used to be viewed purely as a local treatment, and now we're seeing it more as a systemic treatment due to the immune responses that it induces. And so I was also curious about whether you ever thought about, in the dogs that receive radiation therapy, whether to radiate in those that were doing really well over time, and whether that would have potentially had an effect during the course of the booster vaccinations down the road.
Yeah. So the honest truth about the rationale for the boosters was sort of, we thought every 6 months sounded good. I mean, I really can't tell you anything other than that. I can't stand here and lie to you. And you know, it made sense to us that we need to remind the immune system that there is danger there, and keep promoting HER2-specific immune responses. That wasn't in our initial protocol, by the way. And actually, the dogs were coming back, and the owners were coming back with all the papers saying, "Why aren't you boosting my dog? You know, you do so for parvo and you do so for distemper, but you know, you're just doing 3 and off we go." And they sort of have a point. And I think if we want to continue to break tolerance, I think we have to keep reminding the immune system. I think that there's a fairly solid rationale for reboostering the individuals. The timing is a little up in the air. What's the best? Do we have to do it? We have no evidence to say that we have to do it. All of these dogs did receive booster vaccines. All of the owners opted to come back and have another booster vaccine. So we didn't really have a group, and this is obviously small anyway, where that didn't happen. But I think it would be really quite interesting to obviously see. But my sort of theory is that just 3 vaccines up front is highly unlikely to be the cure for this disease. I could be wrong. For the dogs that have the limbs still on, you could argue that perhaps the better way to do that, rather than boosting them, is to follow up with additional radiation to remind them of all those antigens again. And that's something that we just did the booster vaccines again every couple of months, because that seemed sort of a relevant time interval. I don't have anything better. I could try and make something up, but I really don't have anything better. And then why don't we re-irradiate them? That's a great question. I think that we're sort of keeping those 2 additional doses in our back pocket for the patients when they become more painful, firstly. And secondly, you know, the concern about irradiating them is if there is a tumor, a T-cell response in there fighting away, then irradiating them may actually be detrimental to that response. So we've sort of held off that. But it certainly is something, again, we keep it in our back pocket for if and when they get painful again. And then we can see, you know, again, if they develop immune responses, if we see those gamma responses going up.
So I'll just say that people had the same concerns about giving chemo after immunotherapy because you were going to wipe out the response, and it certainly doesn't happen. So I would love to see that experiment, to see what happens if you radiate them. So.
Yeah.
All right. Well, thank everybody for coming, and let's thank Nikki one more time.